Okay, thank you. So you guys, thanks for attending tonight's meeting. Michael, thanks for inviting us. When I got this invitation a couple months ago, I was thinking maybe a brief update of Anchor, but did not think that we'd be spending the entire meeting on Anchor. And of course, Jeff knows better than anyone, and I see Jeff Taylor's on this call, and Peter Bryant's on this call. So there's a number of people that already know that the Safety Monitoring Board closed the study, suggested that there was a big difference between those who were under observation versus those under observation and treatment. And Michael, you suggested, I think very aptly, that we devote this meeting to this important finding. And what a way to end the year on such a positive note. I think this has been something that some of us have been really intimately involved with well before Anchor, for a decade or 15 years before. And I do remember many years ago when one of our nurse practitioners was doing HRA lysis, and we wrote a paper in the AIDS Reader just about all the challenges of trying to get an anal dysplasia clinic at Virginia Mason 15 years ago. And I think Jeff and some of the others who've been actively involved in this can feel the pain, because these challenges persist to this day. But it is really an amazing story that we're going to be telling you about this. And so if I could, Michael, just switch to the next slide, and just kind of standard nomenclature. Neither Jeff or I have any financial disclosures or financial disclosures to discuss. And Jeff will be discussing some off-label products. Next slide. So we thought we would try to break this up into two general portions. And the first part will be a brief slide or two on what causes cancer, an overview of HPV, HIV, and anal cancer risk, which is really pretty standard information. Many of you have heard this a number of times before. We'll discuss briefly HPV and other cancer associations. We'll also get into the epidemiology. Jeff is going to spend a lot of time focusing on HRA, what it is, how it works, what he finds under the scope. And then most importantly, he'll be sharing the Anchor study update as best we can, given that the full information of the study is not available to the investigators. We'll also then spend some time toward the end of the talk talking about the implications of Anchor. And I think these implications are large, and it has everything to do with what the future portends and how easy it might or might not be to integrate HRA and standard treatments across the US, and not just in highly specialized HRA clinics that are existing today. Jeff is going to show some very specific images of what he sees under the scope, and then we'll end it up with some information about AMC HPV studies, and we'll also talk about HPV vaccination. So if I could have the next slide. So again, I think this is really common information for most of you, but what are the causes of cancer? Well, we usually say that 90 to 95% of cancers are due to genetic mutations. And some of those mutations can be passed on to generation. I think the most obvious one would be the BRCA mutation and all the publicity that's been given to that in the backdrop of breast cancer and other cancers associated with that mutation. But the vast majority come from environmental factors. And we talk about environmental factors, it's not just those that are have to do with behavioral factors or pollution, but it has to do with lifestyle. It can also have to do with economic concerns, and I'll talk a little bit about that toward the end. And the causes of cancer that you're most familiar with are tobacco, which causes really 30% of all cancers in the US. I put these little ones in parentheses because I think they've gotten a lot of publicity recently. Roundup, which was a weed killer, has been associated with lymphoma, and that seems like a real association. A couple of years ago, we heard that talc powder, and in particular Johnson & Johnson's talcum powder was associated with ovarian cancer. And then I think it was 2019, Zantac in its then form was taken off the market because of its association with cancer too. Um, Diet and obesity can also have a huge impact. We think of obesity as a chronic inflammatory state, and chronic inflammation provides a really good milieu for the development of cancer. And certainly there are a couple different types of infections that can stimulate cancer, and I'll have one slide on that. Radiation is a potential, and we think about radiation in its various forms, either in the environment or from iatrogenic radiation. Now, there was a large number of people who got leukemias back in the 40s and 50s when you'd go to a shoe store and you'd get your shoe size fixed, or they check to see if your shoe fit. They take an X-ray of your foot, and all of that kind of very old style ionizing radiation we found out later was associated with cancer. Additionally, if you remember, those of you who've had not digital watches, but watches that used to glow in the dark, not because of an LED, but because they were painted on with iridium. That's a radioactive substance. And the people who used to paint those dials would put the tips of their brushes in their mouth and then paint the things. And those caused cancer too. On this slide here, we took 4 different viruses that are clearly associated with cancer: HPV, HHV8 or KSHV, human herpes virus type 8. That's the one that causes Kaposi sarcoma, but it's also associated with other cancers, including rare forms of lymphoma, hepatitis B and C, which can be associated in the case of hepatitis B with liver cancer. Hepatitis C can cause liver cancer, but it also can cause different forms of indolent lymphoma. And then Epstein-Barr virus, which we know is cause for about 30% of certain types of lymphomas. Interestingly, I saw a patient a month or 2 ago who got really sick from COVID and had rheumatoid arthritis and underlying HIV, and he was on disease-modifying therapy for his rheumatoid arthritis, and he got terrible COVID. But when we did a CAT scan on him, he had multiple nodules in his liver and his spleen, and one of the lesions was biopsied. It turned out to be a leiomyosarcoma, which is a soft tissue cancer. And that very rare cancer, which we typically would see only in children with HIV, is associated with EBV also. And then there's one I didn't highlight, but HTLV1, which is a cause of leukemia and lymphoma. And in Japan, in southern portions of the Japanese islands, as many as 15 to 30% of people are infected with HTLV1, and that's by far and away the most common cause of leukemia and lymphomas there. HPV is obviously the virus that we're most interested in tonight. And what I mentioned in this slide was that immunosuppression and inflammation are the main drivers of cancer in the backdrop of HIV. And we don't think of HIV as an oncogenic virus, meaning in itself, HIV doesn't cause cancer, but it can promote inflammation. It can have a number of different delayed reactions to a viral infection or other infections that can then stimulate cancer. Next slide. So I think one of the things we know is that there's a higher incidence of AIDS-defining cancers in HIV folks. And in this slide, you can see that non-Hodgkin's lymphoma, which has gone down considerably over the last 10 years, still represents a higher number in this group. It's 88%. Kaposi sarcoma, 100%, and cervical cancer, 66%. But the non-AIDS defining cancers are very real. And I think what I wanted to point out here is that actually breast, colorectal, and prostate cancer have lesser incidences in the context of HIV infection. And I don't think that's necessarily because they have less cancer in this group, but there's less screening, there's less diagnosis.
Mm.
And we think that that is one of the highlights that emphasizes this disparity in care among those with HIV and those without. And some of this is broader than just whether you're HIV positive or negative. It has to do with where you live. It has a lot to do with your economic station as well. Next slide. So the known risk factors for anal cancer, I think, are very familiar to a number of you. There are 12 different strains of HPV that can cause cancer, but the main oncogenic strains, the main types that are the largest drivers of anal and cervical cancer by far and away are the HPV serotypes 16 and 18. We know that older age is a risk factor for anal cancer, so typically patients are older than 50, and they often have low CD4 counts. And I think what we found with Anchor and with some of the information we heard on a shared Zoom call maybe a week or two ago, was that it's not necessarily a low CD4 count, but rather a history of a low CD4 count. So what your CD4 count was at the very lowest time in the course of your illness. Smoking is definitely a high risk for all types of cancer, and it potentiates precancerous conditions. And the association between cervical and anal cancer and HPV, as well as HPV-associated oral cancers, is very large. And then women with high-grade changes or precancerous changes in the vulva and cervix are also risk factors for anal cancer. And we think of this as a field effect. It's not just the anus, it's not just the cervix. It's really the area between the cervix or the vagina and the anus and everything in between there. And then genital warts in themselves are not typically oncogenic or cancer producing, but they're an indicator of HPV infection, and it put patients at a little bit higher risk as well. Next slide.
Can I ask a question while you're on this slide?
Sure. Oh, I'll go back.
Thanks. So I want to be clear on the connection with CD4 count, because I got my diagnosis. I was above 400 when I was diagnosed with full-blown anal cancer. And I've heard a lot of other people who had higher CD4 counts. Now, I know you said it was the nadir that was important, but when I give my workshops, I always say that it's possible to get anal cancer. I mean, not just HSIL, but real anal cancer, even at higher counts, right? I mean, have you seen people getting it above 500 because they had a low nadir? What's the story I should tell people about CD4 counts current and the risk of anal cancer?
Yeah, it's a good question. I think what you could tell them is that, you know, a history of a low CD4 count is a high risk feature, but a CD4 count of 500 doesn't preclude the risk of anal cancer. And we would not, you know, begin to suggest that anal cancer screening be demarcated between high CD4 count or low CD4 count. You know, it takes years probably from the time of HPV acquisition to the development of anal cancer, but certainly people with normal CD4 counts, or in that case, normal being over 400, could definitely get anal cancer.
Because I was told there was some unknown interaction or something between HIV and HPV, that it was having HIV itself that actually gave you the higher risk for anal cancer. Do you agree with that?
No, I don't. And Jeff, I could let you give your thoughts too, but no, I think HIV in itself would not be associated with that significant risk, but it's HIV with HPV together.
Yeah, no, that's what I meant. I mean, having HPV, which almost all of us have, but there's some symbiosis or whatever, some question of having HPV and HIV, that there's some interaction we're not sure of that actually significantly increases your risk.
Absolutely.
Right?
Absolutely. So the risk for men who have sex with men versus those who have sex with men and are HIV positive is about a threefold difference. So the higher risk in the context of HIV, higher in men who have sex with men, as opposed to men who have sex heterosexually. So HIV
And
has a very,
and we still don't know what that actual connection is between the virus HIV and the virus HPV, but there's something there, right?
yeah, there's a lot there. So we don't know all the steps in carcinogenesis, but the benefits of immune surveillance, the benefits of the ability to take a precancerous lesion and keep it precancerous rather than let it transform probably has a lot to do with T cell mediated immunity as well.
Thank you.
And David, we had another question in the chat from Alistair. Does a low nadir signify more than a prolonged low but not nadir CD4 count?
No, a nadir CD4 count just implies that at one time or another, the T cell count went to a low number.
Right.
Now, most people, again, it depends on their age, but let's say your CD4 count is 200 and then you begin HIV medication. If you're 30 years old, we may find that CD4 count go up to 300 or 400 within a year. If you're 50 or 60, or if you have hepatitis C or some other issues, it may never go up, or even though the viral load is not detectable. But most people in the context of antiretroviral therapy will see a very robust response. And I think the information we heard the other day from Joel Pileski was that the CD4 count was around 600 for most of the folks who had gotten invasive anal cancer. That was not their nadir CD4 count, and many of them had very low initial ones. But I think one of the surprises, kind of to the questions that were first brought out, was that a CD4 count of 500 was not unusual to have anal cancer in that context.
Thank you.
Yes. Next slide. So again, just a couple of quick facts. What we do know about anal cancer, it's more frequent in HIV positive men and women than in the general population. Men who have sex with men are 35 times more likely to develop anal cancer. And then this kind of gets to those first series of questions. But if you're HIV positive, it's about a threefold or fourfold higher risk than in HIV negative men. And we do know that the incidence of anal cancer is rising in HIV positive men and women, and that's despite the benefits of HARD. Although I think we're having an emerging understanding that HARD is, or ART, is very useful in this context, and it looks like it is having a modifying effect on invasive anal cancer. And Jeff is going to talk about this in a couple moments, but this notion that a precancer evolves into an invasive cancer just doesn't come out of nowhere. And these precancerous changes, which are called high-grade squamous intraepithelial lesions, or HISL, is really what Jeff and other HRA specialists are all about when they're doing this screening. Next slide.
David, could I also note here on that previous slide there, just to put these relative risk in context, the incidence of anal cancer in the general population is about 1 to 2 in 100,000 people. And actually, it's more common in women than men, but those tend to be more sporadic cancers occurring in the general population. These relative numbers are very high, but keep in mind the baseline risk is pretty low. So most people with HIV don't develop anal cancer. The relative risk, though, is much higher than in the general population, which has a risk of about 1 to 2 per 100,000.
Yeah, that's a really, really good point, Jeff. And I think it might show it on one of the next slides, but if we say in the course of a lifetime, the risk may be 10%, and that sounds like a huge amount, but to put it in perspective, the risk of breast cancer in a woman in the US is about 12 to 13% in the course of her lifetime. So that 10% or 1 in 10 risk is in the course of a full lifetime. Next slide. So I wish I had taken a different slide, and I didn't notice this till after, but this is just a really useful, I think, diagram showing what on the left hand of at least what I'm looking at, which it says normal, is what normal anal epithelial looks like. And it has this very normal kind of large cells. And then as you move on from a low grade to a high grade changes, there are very characteristic cytopathology changes that are evidenced. And, you know, when we go from normal to low grade to high grade, these are very characteristic lesions that are seen by the pathologist. They'll report them out on their cytology. And this kind of gradient from normal to low to high grade changes are very similar, if not identical, to what's seen in cervical cancer. And so the way that pathologists weigh these out are very, very similar. And what I'd really call your attention to on this slide is at the very bottom, if you can see this, there's a diagram and it says microinvasive carcinoma. And this kind of collection of these small cells with high nuclear to cytoplasmic ratio. And basically what it's supposed to show is that the cancer cells have broken through the membrane of the epithelium and are now potentially coming in contact with lymphatics or blood. And so this could spread to other areas. And so there's this gradient from precancer to dysplasia or altered changes in cells to high-grade changes. And it's really, the anchor study was really about the high-grade changes, trying to catch those early and treat them before they could break into that microinvasive or frankly invasive anal cancer. Next slide. So again, what is the risk of HSIL? If you're HIV positive and you have sex with men, it's about 5 in 10. If they go through the careful HRA exams that Jeff and others do, about a 50% chance that they'll eventually find some form of anal dysplasia of a higher grade, the kind that we might want to do something about. Next slide. And then I mentioned this a minute ago, but you know, people, the vast majority of people who have high-grade changes do not develop anal cancer. But if left unattended, we think that that risk is about 1 in 10 in the course of a person's lifetime. Next slide. So among women, it's estimated that 2 out of 10 who are HIV positive have these high-grade anal changes. And next slide. And we're not really sure how many women will get anal cancer. There have been a couple recent studies. Liz Chow and some of the folks from the AMC did do a large retrospective study and then a prospective one looking at the risk of high-grade changes in women. And we're finding that the risk, you know, there are more than we originally presumed, but we still don't know exactly what the risk of anal cancer is. I suspect or presume that it's not going to be much different between men and women. Next slide. So I'm pretty much coming to the end of my portion until Jeff, and I'm going to have Jeff take over in a minute. But this is just a kind of an overview slide showing the different types of cancers that HPV can be associated with. And so penile cancer is incredibly rare, and you can see that in the course of a year, there may be 1,000 cases diagnosed in the US. Cervical cancer is far more common, and you can see where anal cancer comes up against cervical cancer. And a large reason that there are so few cases of cervical cancer, relatively so few, is because cervical cancer screening has been going for so long, and that's such a fundamental part of the care that women receive in the US. But as we talk about it being a field effect, anal cancer, vaginal cancer, vulvar cancer, and penile cancer all have this very real risk of invasive cancer. I don't think it was really appreciated that a large number of head and neck cancers are associated with HPV. And now that we routinely do HPV testing on all head and neck cancers, we appreciate that maybe 30% come from HPV. And so when we talk about the importance of vaccination. It's not just for anal cancer, it's not just for cervical cancer, it's for this very large risk. If you look at it, there are far more people that die in the US from head and neck cancers than they do from the other types of HPV-associated malignancy. Mm-hmm. And again, of this group, often it's related to smoke and alcohol, but about a third of the time it's clearly related or connected very closely to HPV as well. Mm-hmm. And then the one little one that's back up in the right, my right lower corner, sorry, one slide back for just
a yep, hold on.
Is this one called conjunctival cancer. I have never in my life seen a case of conjunctival cancer, but for those of our Harborview colleagues that do spend a lot of time in sub-Saharan Africa, it's not that uncommon there. And HPV serotypes have been associated with that cancer. It may be associated with UV radiation. It may also be with chronic inflammation when wind whips sand into eyes and stuff, but it creates a milieu to develop that kind of cancer too. So maybe with the next slide, I'll let Jeff take over.
Okay.
All right, great. Thanks, David. So prior to the ANCHOR study, and actually under the current guidelines of the American Society of Colorectal Surgeon, the main screening for anal cancer has been the digital exam, what we call digital anal rectal exam. This is actually, if done properly, a pretty good way to feel for any lumps or bumps in the anal canal. Most of the anal cancers that I've seen, I've been able to feel something a little abnormal that got me concerned before I even put the anoscope in and took a look. So this is an important exam, but with prostate cancer screening, a lot of providers, primary care providers, no longer do the digital anal rectal exam because they thought the only reason to do this was to feel for the prostate, and now they do it through a blood test. So this is it's an important exam. It's not adequate to pick up high-grade dysplasia. One thing I should note, high-grade anal dysplasia is always asymptomatic. You don't know you have it until you have the exam, with rare exceptions. So it's something that we find on exam, but you don't know it until you have the endoscopy done, and we'll talk about strategies for detecting it. Next slide. Mm-hmm. So this is a curve, and if you go one more, Michael.
Sure.
Okay, so this is just, David was talking about the incidence related to age, and you see on the axis here, the x-axis age, and virtually most all cancers, with few exceptions, the risk increases as we get older. And these lines here, the solid line is the current period, and the solid line rather is the most current data. The dotted and dashed lines are the older data. So things like Kaposi sarcoma and non-Hodgkin's lymphoma are occurring less frequently in the current time period. But if you look at the ones that are circled there, the non-AIDS defining cancers that David talked about, the lung cancer, liver cancer, colorectal cancer, anal cancer, are all more common now than they were earlier in the HIV/AIDS epidemic. One feeling is that people are living longer and are at greater risk for some of these other non-AIDS defining cancers. So this is a concern. So the question earlier about current T cell count does not protect you from cancers. Most everyone in the ANCHOR study had undetectable viral load and good T cell counts. Next slide. So the other thing is HPV is incredibly common, and there's so much stigma associated with anal sex, so much stigma associated with HPV, and it's really unfortunate because people oftentimes don't seek care in a timely manner for the stigma associated with these issues. But anal cancer, HPV is super common. This was a survey done on self-collected penile and cervical vaginal swabs, and any HPV or high-risk HPV, which are the types of the oncogenic strains that David were talking about, were significantly more common in men and differed by age and race, and we'll show that, and lifetime partners may explain some of this difference. Next slide. But if you look at the prevalence of general HPV in the United States, now this is not HIV population, just a general population screened with swabs. Overall, it's very, very common, and more common in certain groups like non-Hispanic Blacks and Hispanics. The solid line is any HPV, the dashed lines are the high-risk HPV. So even the lower dashed lines are very common. And as you see, they persist over time. One reason we think that people with HIV are more likely to develop anal cancer is these high-risk anal types are less likely to be cleared by the immune system and persist over time. So these strains of HPV are very common in the general population. Next slide. So I'm going to just show a couple of what this exam is about. Many people come to see me, they're referred by their primary care provider and have no idea what they're coming in for and what kind of exam it is. So I think it's important just to show you a couple of quick pictures here. This is what we call the anoscope. It's basically a microscope that we're looking into the anal canal with. Take pictures there for the record. Next slide.
Yep. So is someone sitting on their back that way? Is that?
There, you'll see the next picture. They're lying on the
cool.
left side.
Sorry.
Yeah. And this is basically all we use. This is a little anoscope, that little plastic scope in the foreground is the anoscope. It goes in about 5 inches into the anal canal. The skin goes into the anal canal about 1 or 2 inches. That's where HPV loves to live, in moist skin before it transitions to mucous membranes. HPV doesn't infect the colon or mucous membrane, so there's no association with HPV and colon cancer. It's all the skin, and the skin particularly just inside the anal canal. We use little swabs to put vinegar and iodine on. I'll show you that enhances the differentiation of normal and abnormal tissue. The whole exam takes about 15 minutes. You don't need to do any prep, no enemas or anything. And for most people, I would say it's an uncomfortable exam. It's not a painful exam for most people. Next slide.
Quick question.
Go ahead.
Yeah, go ahead.
So my anoscopies, there's never a camera. It's just a tube in his eye, right? Is that how it's normally done? Just with the tube?
If it's the high resolution anoscopy, means specifically done with a microscope and vinegar and iodine.
Okay.
So
but,
anoscopy just means looking with the scope. The high resolution piece is the microscope and the vinegar and iodine.
Okay, thanks.
So this is the anal pap smear we sought out, and we'll come back to this at the end because this we're going to have to talk about how we screen for high-grade anal dysplasia. So this is the anal pap smear. A small Q-tip goes into the anal canal and collects cells. Next slide. And then that little plastic anoscope goes into the canal, and then we're looking through the microscope. It takes a while to do an adequate exam because you want to see through the circumference of the anal canal, through the depth of the anal canal, and see all the folds. Always some hemorrhoidal veins swell up just on the pressure of the scope. So I would say it takes about 15, 20 minutes, as the slide said is pretty accurate for doing a complete exam. We often will take biopsies. Biopsies are little pinches of tissues in the anal canal internally. There aren't many nerve endings, and they're uncomfortable, but they're not terribly painful for the most part. Next slide. So this is the anchor study. The study, the design of the study was to screen HIV positive people 35 years of age and older. Anal cancer never develops in people in their 20s. Rarely we can see it in people in their 30s, and I've seen several people in their 30s with anal cancer. But mostly, as I showed you on those earlier slides, the age increases, the risk increases as you get into your 40s, 50s, and 60s decades. So this was men and women over 35, very simple eligibility requirement. You didn't have to be on antiviral therapy. Most people were. If high-grade dysplasia is found at screening, then you're eligible enrolled in the study. People were randomized 1-to-1 to what we call an active monitoring arm, where there was no treatment of the high-grade dysplasia. The intervention arm, the high-grade dysplasia, was treated at baseline and whenever it was identified. And we'll talk about what that treatment involves. So people were seen twice a year. And the study was to go on for at least 5 years after the last person enrolled in the study. So this is the way the study designed. It was estimated that about 50 people would develop anal cancer in this study over the 10 to 15 years of the study. So next slide. So over the 5 years of the participation in the study, people were supposed to be followed for 5 years after the last person enrolled. We'll show you where we are with that now in a minute, but every 6 months had a blood draw, some anal pap smear swabs, both for cytology, looking at the cells, as well as for typing, for looking at the HPV types. As David said, 16 and 18 are the most worrisome types, but we see a lot of other high-risk types on these anal swabs in our clinics as well. And the anal biopsies as necessary, and treatment is what we call hyperication or ablation. I'll talk about that in a minute. And everyone got a compensation for their time and effort of $100 per visit. Also unique to this study, We paid everyone's co-pays deductible, so no one had any out-of-pocket expenses while they were on the study, which was quite unique actually for this study.
That's
For a
awesome.
study like this. Next slide. So the primary objective was to determine whether treating of anal high-grade dysplasia, or we call HSIL, is effective in reducing the incidence of anal cancer. So the primary endpoint of the study was invasive anal cancer. Secondary endpoints were looking at the safety of the different treatments, and I'll go over these in a minute, and also looking at some other exploratory things, looking at viral factors, biomarkers of progression of high grade to cancer, which is going to become more important going forward as we look at the results here. Next slide.
Can I ask a question first?
Yeah.
So because the study was stopped early, will all of these secondary objectives and exploratory objectives still be able to be fulfilled?
So what was stopped was enrolling and screening new people into the study. Well, as I'll show you in a minute, we've enrolled 4,500 of the 5,000 people, and we will continue to follow those 4,500 people until August of 2025.
Oh, great. Great.
Okay.
Yep.
Yeah. So what we stopped is enrolling and screening new people. Everyone on the study will continue on the study another 3.5 years.
Awesome.
So the study, basically the assumption of the study design and how they came up with 5,000 people followed over that time. The statisticians assumed there'd be an incident rate of about 100 per 100,000. Remember, David said the incident rate was, 100 times higher than in the general population. So that's the general population is 1 to 2 per 100,000. So it's assuming there was an incident rate in this population of 100 per 100,000 among all HIV infected men and women. And assuming that the anal cancer precursor is high-grade dysplasia, the hypothesis being that if we treated the high-grade anal dysplasia, we would decrease the chance of anal cancer developing. So if half the population wasn't treated, then the expectation would be we'd see about 200 per 100,000 cancers in that group. So next slide. So these were the study sites, about 25 sites around the country. This was a very difficult study to get up and running. The initial budget for this study was about $80 million, funded by the National Cancer Institute. A lot of training to get these sites up and running. Next slide. We had sites here in Seattle at 3 institutions, at Harborview, Virginia Mason, and Polyclinic. Polyclinic unfortunately closed all their clinical research in January with new ownership of 2020. And those participants, as I'll show you, transferred over. Dr. Wanda Laosa was doing the study at Polyclinic, and I was an endoscopist at the study at Harborview and Virginia Mason sites, starting in 2015. Continue, next slide. So a couple of important things about this slide. This is the data as of October 24th, when the screening and enrollment was stopped by the Data Safety Monitoring Board, as David mentioned. Nationally, if you recall earlier, there was supposed to be about 15,000 people screened to enroll 5,000. We thought we'd see about 1 out of 3 people be eligible for the study. Actually, we found that 1 out of 2 people were eligible for the study, meaning they had high-grade anal dysplasia. So this was very common in this population. And the only screening criteria was being HIV positive and age 35 or over. We screened 151 people at Harborview, at Virginia Mason. Actually, that includes some of the Polyclinic. Once the Polyclinic closed the clinical research program, Dr. Wanda Laosa was able to come over to Virginia Mason and transfer his participants for Polyclinic over to Virginia Mason, so that they're included in those totals there. But you can see what we screened totally and enrolled in the study here locally out of the total of 4,500 people, just over 4,500 people who ended up in the study before the enrollment was stopped. And Jeff, on October 24th, yeah.
Yeah. Was this seen elsewhere in other sites? The high and 1 to 2 enrollment.
Yes, yeah. So the top is nationally, and that's what we saw here too.
Okay, great.
So the pie chart on the right just shows the that the reason of the screen, what we call screen failures, that half of people weren't eligible for the study. The vast majority was, fortunately for them, they didn't have any high-grade anal dysplasia on the exam. None of these people were referred because they were symptomatic per se. We tried to screen anyone and everyone over 35 in our clinics. So there was no real selectivity. So it just shows how prevalent high-grade anal dysplasia is in people living with HIV. One other thing I should mention here, there's tremendous stigma associated with anal cancer, anal dysplasia. You don't have to have receptive anal sex to have anal dysplasia or anal cancer, particularly in older women that I see with high-grade anal dysplasia. The first thing most people tell me, well, I've never had anal sex. HPV likes to live in the genital tissues, and once it's there, it will go in the anal canal, it will go in the vagina. It doesn't mean that people have had anal sex, and that's important because some people get a false sense of security that they don't have anything to worry about because they haven't had receptive anal sex. Next slide. So these are the two main treatments we use to actually treat. Important to note, the anchor study didn't compare different types of treatments. You either got randomized to treatment and the clinician chose and made recommendations on what the best treatment was. We used to use this machine on the lower right, which was an infrared coagulator. Now we use this bifurcator, which is a little electrocautery. It's quick and easy for the treatment. The recovery is quite robust without nothing like when people used to go to the operating room and have more aggressive ablations in the operating room. These outpatient treatments, people do very well after for the most part. Next slide. There are other topical treatments that we use that we could use in the anchor study. These are different compounds that are self-applied. These are not FDA approved for treatment of high-grade anal dysplasia or intraanal application. The two we most commonly use are the imiquimod or Aldera and 5-fluorouracil and Efudex. The imiquimod requires some immune-enhanced response and doesn't work as well in people with HIV in general. So the topical cream we tend to use is 5-fluorouracil, which is a chemotherapy compound. These are applied, self-applied over a period of many months, cause a lot of local irritation, are rather difficult to use. We tend to only use it in people with circumferential extensive high grade to try to reduce the amount of high grade we have to come back and ablate down the road. So again, the anchor study didn't compare types of treatments at all. Next slide. So this was at the September, the Data Safety Monitoring Board is a group of outside experts that review the data from the study about twice a year. And this is part of the ethics of performing research, is that you want to be sure that your study, number one, is being conducted safely. And you also want to know, did you answer your question earlier than expected? And that could be answered either in a positive way where, yes, A showed it was better than B, or it could be that there's no difference and you're never going to answer your question, what's called futility, and there's no reason, it's not ethically sound to continue to do the study. So the Data Safety Monitoring Board looks at all three of those issues at the meetings. And what they determined was that treatment reduced the risk of anal cancer significantly better than the active monitoring approach, meaning there were much fewer cancers in the group that had treatment with the bifurcation compared to the groups that were being monitored and not treated. So after consultation with the sponsor, National Cancer Institute, the study enrollment stopped and screening stopped, but the study didn't end. We're continuing to follow everyone in the study. And we also are going to be offering everyone who is in the monitoring group to come back in and be treated now. So a revised version of the protocol will now offer all monitoring participants treatment of high-grade dysplasia, and everyone will continue to be followed in the study until August of 2025, which is the end of the current AIDS malignancy consortium group under which this study is being administered. Important caveats are that some people in the treatment arm did develop anal cancer, and some people in the monitoring arm had their high-grade lesions go away without treatment. So one message here, the manuscript's being written, there'll be much more detail of the specific outcome events, number of events, and so forth. And that should hopefully be in press within the next month, we hope, and have more details. But one message of this is we still need better treatments, but treatment is much better preventing anal cancer than monitoring, meaning not treating it. And this was an area of serious debate. As I said earlier, the American Society of Colorectal Surgeons doesn't recommend doing high resolution anoscopy. A lot of people feel like, well, you should just wait, and if cancer develops, treat it, because they didn't think that treatment would prevent anal cancer from developing. And it turns out it did. Next slide. So a couple of implications, and I'll let David comment on these too here after these couple of slides, and then I had a few other slides if we still have time to go over on a few other studies in the vaccine issue. So, this was people with HIV. Do these findings apply to other immunocompromised people? We see a lot of people who have had bone marrow or solid organ transplants, people on immune suppression for other autoimmune diseases who have high-grade anal dysplasia and are at risk for anal cancer. how best to screen, and we'll come back to that on the cytology. And what about how will current screening guidelines be changed? And it takes a lot of expertise and training to learn how to do high resolution endoscopy. I've been doing it since 2012, and I still get very humbled about how challenging it is to do these exams. So next slide.
Mm-hmm.
So hopefully we'll look at some screening algorithms, and I have a couple of slides at the end to talk about this. Why don't you go back one slide, and then
Sure.
I'll let David ask if he has any comments, and then we'll go on to the other slides. Because I think David has a few more slides after the next slide or two.
Okay. Well, while we're waiting for him to come back on, I had a question too, just because I know that you were talking about MSM and then HIV positive MSM. So my wondering is around, do these findings apply just for MSM in general?
You know, my personal feeling is we don't know, because this, you know, the common link here with these other problems is immune suppression.
Right.
Whether treating of high-grade dysplasia will make a difference in anal cancer and MSM without immune suppression, I don't know.
Okay.
My gut feeling is it probably will,
Right.
but I think the risk of progression is lower. So the other question, which once the data is presented in manuscript form and published, is going to be the risk-benefit analysis. We treated a lot of people. I would say about half of the people with high-grade dysplasia needed multiple treatments. It doesn't go away in one setting unless you're treating one small area usually. And so there is a risk-benefit issue and equation that has to be considered here too.
Great. David, are you with us?
I think first, what a great presentation that Jeff gave. And, you know, I think that Jeff is right. It takes a lot of time and a lot of experience to know how to do this exam and to see what you learn from it. I don't do HRA, and I am not skilled enough, you know, with my hands to do what he can do. But I'm always impressed, you know, every 6 months we have the anchor meeting, and in it, there's a day and a half devoted to just the HRA folks describing their cases and describing their difficulties getting a diagnosis. And it is always one of the highlights for me to hear at the challenges and the difficulties that each one of them have experienced. And it doesn't matter if it's someone who's been doing it for 2 years or someone who's been doing it for 10 years. There are a lot of commonalities, a lot of finesse with this that is going to represent real challenges, because I think when we think about what are some of the implications to this study, you know, I think early on we were very pushed back about all the rigmarole that the HRA folks had to do to get certified and trained. And it was, you know, in some cases a couple of years process for people to get their cases, have them adjudicated, be allowed to have someone from San Francisco, New York come and watch them personally do 10 such cases. It's just been a major effort. And when someone like Jeff retires, the amount of knowledge that he has gathered is going to be lost. And how this information is going to be transmitted to a new crop and a new group is a challenge that we're all working with. And I think we've seen that in the Anchor Consortium, that, you know, people are coming and going all the time. Some people are at the back end of their career, some are at the early part of their career. But how do we develop a sophisticated training schedule that'll ensure that enough people want to do these kind of tests and have an interest in them, and that clinics will support them? It's just one comment. The other, just looking at this slide, you know, I do think this very much applies to other immunosuppressed folks. And when we think of particularly the organ transplant folks, the renal transplant folks, they're on really heavy duty immunosuppression. And, you know, I think what we're finding in their cases is that they don't have ART to restore their immunity. They remain severely immunosuppressed throughout the duration of their life. And they have a significantly high risk of these kind of cancers. And I expect that we will not be able to do an anchor study with other populations. And I think it will get generalized over time. That's my guess right now. So let me go to the next slide.
Before we do, since we were on this topic, Alistair had some questions about the training of HRA folk. Alistair, did you want to unmute yourself and ask your questions, or you want me to do it?
Thank you. I'm happy to ask them.
Go ahead.
Essentially, I was curious if there was any educated estimate as to how many more HRA folk will need to be trained so that this can become something that is done for the general population, equivalent to the way cervical screenings are done.
No, that's a great question, Allison. We're starting to have some discussions even locally here at Harborview and Virginia Mason about, part of it is until the paper's published and the guideline changes, we're not sure what the general uptake. You know, some people may not still be convinced that treatment is worthwhile in this population. If you look at the risk-benefit analysis and so forth. So it's going to take a little while to get a sense what the need really is going to be. The other challenging thing here is there's a whole variety of different people have come into this field just due to kind of oftentimes through HIV clinical involvement. I'm a general surgeon by training. A lot of people who do this are non-physician providers, nurse practitioners, physician assistants. There's gastroenterologists who do this. There are other general surgeons who do this. There's gynecologists who do this. Someone's going to, I think, have to take ownership really to set up programs and training. Now, I'm a little biased towards surgeons because some of the folks do need to go to the operating room for more challenging lesions. But I think part of it's going to be who takes ownership of this down the road also, and how that training capacity is going to be developed. David, do you have any thoughts on that?
Yeah, I think.
I mean, you know how we struggle to provide this locally.
Yeah, we've talked about this a lot. And, a decade ago, Liz Steyer, who now runs the HPV group for the AIDS Malignancy Consortium, wrote an editorial in the Annals of Internal Medicine saying that this was something that gynecologists should do because they use HRA every day and colposcopy every day in their clinic. And the lessons of one so overlap with the other. And at the time, the Gynecology Society really fought back very strongly and said, this is not in the purview. These are men and we don't see men. It's not in our purview. And it went back and forth quite a bit. It developed a lot of controversy, but without any consensus. And the vast majority of people who do these are not gynecologists, but that's another group that would be well-trained. They're surgeons, they do colposcopy all the time. But I think it's a big issue, Alistair. And you mentioned, if we think about how many people do we have in Seattle to do this? Well, we have Jeff, we have Wanda Laosa, we have another physician, Jeff, I don't remember her name, the infectious disease doctor at your clinic.
Yeah, Dr. Helen Sankowitz-Karita.
Thank you. And we have two PAs who do it at Virginia Mason. It's not nearly enough to accommodate all the people in Seattle. And we have a plethora. We're part of that anchor study. If you look at every, that overview of, I think it's 20 cities in the continental US that are part of anchor or something like that. There are whole cities and states and whole regions of the country that don't have a true expert to do it. So I think it's going to be a real question. And I think it'll depend a lot on how that paper is received, and how it changes things. I think we're all thinking it's going to make a very big change. And during the anchor information call the other day, someone mentioned, well, back as early as 1990, colonoscopy was not routinely done for colon cancer. I didn't know that, but they said that was true and that there weren't a large grouping of people who knew how to do colon cancer screening. But within 2 or 3 years, most gastroenterologists had been trained up to do it. So it'll be interesting to see what will change because of this, because this is only one small segment who would benefit, I suspect, from this kind of screening.
And also, I want to point out in the chat that Laurie mentioned that the Mountain West AETC offers HRA preceptorships training in Portland, Oregon, as in Colorado. So
those would be for gynecologists, I assume, not for anoscopy, though. I don't think, Laurie. I'm not aware of anyway.
No, it's for anoscopy.
Oh.
Yeah, it's one of the Ryan White clinics in Oregon is offering it that we work with.
Oh, okay.
Yeah.
Awesome.
Well, that's good to know because we see a lot of people coming up from Portland to see us here. So it'd be
Oh,
nice
that's interesting.
if you could let me know who that is, send me a message. I appreciate it.
Sure, I'd be happy to.
We
Alistair,
currently see people from Alaska to Montana in our clinics here in Seattle for this procedure.
wow.
Okay. Yeah, I'll get you the information.
Great.
Alistair, did you have your question again? You had a hand up?
My hand was up partially for the second question of is there the start of any plan to increase the number of HRA folk being trained? But more specifically, it crosses my mind that the folk in an ideal situation to give a jump start to that training are the folk who are carrying out the remainder of the next 4 years of the anchor study. That they're well positioned to potentially find people and encourage them to take part in terms of being trained. But more specifically, part of the training is likely to be finding some volunteers who have very well-defined margins between colon tissue and rectal tissue to make it easy at the beginning to help train them to find those margins and then be able to work backwards out of the rectum from that point.
Well, this is challenging to train people. I think that as soon as, once the paper's published, we do plan to meet with our colleagues in gynecology, general surgery, and internal medicine, and do identify people who are interested who want to be trained. I would say that this is very different than cervical colposcopy. And actually, some people have said that it's actually quite difficult to retrain people who are used to doing cervical colposcopy to do anoscopy. The only gynecologists I trained decided they did not want to do it once they started doing it. So it's not going to be a natural transition for a gynecologist to start doing high resolution anoscopy. It's a very, very different exam.
I agree with you totally, Jeff. It's a different exam. It's a more difficult exam because of the folds and the soft tissue associated with the anus. And we did try, 15 years ago to get our gynecologists to begin this process. And there was humongous pushback. They didn't want a lot of men in their clinic at the time. Hopefully that'll change as this becomes a more accepted approach. And I think there will be a lot of stimulation, a lot of new blood with this kind of study being reported.
David, you had a few more slides. Did you want to go through those?
Go to the next slide.
Okay, I just did.
Next one.
Next one.
Yeah. So I won't ask the question, what is a DSMB? Jeff is a lawyer, but among his different hats, and he did a great job of explaining the importance of a DSMB. I think anchor is kind of like a hallmark. It is an emphasis on the importance of cancer screening in a very general way and in a more specific way for anal cancer. And, in May, there's going to be a very large cancer disparity conference that's going to be here in Seattle. And its focus is really on identifying barriers to care and cancer screening and the like. And I know a couple years ago, I heard a talk by a physician in Chicago who looked at survival of prostate cancer on the basis of area code. And he was able to show that if you live next to Northwestern Hospital in Chicago, kind of a Tony area, you had the best survival in the country. But if you lived in the boroughs of Chicago on the south side, that area code predicted a survival that was very, very much similar to third world countries. And that notion of disparities of care and access to care are humongous. And I think Anchor is going to highlight some of it. I think we're always trying to get a representative group of people into clinical trials. And one of the big criticisms of the National Cancer Institute and the NIH right now is that the people who are participating in the trials aren't reflective of the people who are actually getting the cancer, getting cancers. And, we have some real leaders on this Zoom call tonight from the national and from our Seattle Anchor Cap. And I think one of the highlights when this study comes out and additional many studies come out of the Anchor study itself is going to be the way that this study reached out to people of color, of women, of, under a huge stigma along with HIV, and as Jeff has already eloquently said, HPV. So I think there's going to be a lot of huge lessons, including how do you run a clinical trial? How do you get more people involved? How do you make it equitable? And offering $100 in cash is a very small way, but it made a huge difference in getting people to come to clinic, getting them to be able to pay for cabs and other things that really are huge barriers for a large portion of people.
And taking care of the copay, I would imagine, was a great incentive, a great help over a barrier.
Oh, it's huge. I mean, back in the early days when we were doing this, we'd get patients in, they'd get an anal cancer screen, they'd get a biopsy, and then they'd get a bill for $700 to a couple $1,000s. And we never saw those patients in those clinics again. The other thing I wanted to say is that cancer screening doesn't take place in a vacuum, and there's been a large impact with COVID-19. And if we could take the next slide.
Sure.
I mentioned that there are disparities in cancer care with HIV. And, this is a slide that shows kind of the non-AIDS defining cancers, which are now more prevalent than the AIDS defining cancers. And lung cancer is a huge one. I mentioned breast cancer, colon, and prostate cancer. These are things that we can screen for right now, but we don't do a very good job of it in certain populations. And hopefully we'll be adding anal cancer to this as well as part of what we think will become fairly routine screening. Next slide. So I mentioned this, I think, a year ago at one of our CAB talks. Seattle Times had a great article. I think it was on the front page. This was early in the pandemic, and it talked about the echoes of HIV and COVID and how things seemed oddly alike, and yet there were many things that were very different. And I wanted to highlight this, and I think some of us recognize a couple of the people in these slides. I'm not talking about Donald Trump or Ronald Reagan. Next slide. So I think that, if anything, COVID has really shined a brighter light on healthcare disparities. The fact that some people get certain treatments and others have no ability to access those treatments or even are aware that they're available. And I think this has been a continuing message as we've heard throughout COVID. Next slide. So cancer care has changed a lot in just the last year. And, it was really weird at this time. Well, I would say about a year and a half ago, March or April, there was an article in the Seattle Times. It said that University of Washington lost $500 million in the first couple months of COVID, as people weren't coming into the hospital, they weren't coming to the emergency room. All the elective procedures got put on hold as people were suddenly and understandably scared that they might get COVID from coming into the hospital. And at the time, I remember thinking, oh, we're protected at VM. We're relatively small. We're about the 10th of the size of the UW. And the furloughs and the loss of jobs and the disorganization that was taking place, I thought we had pretty good, until about a month later when we physicians took a pay cut for temporarily. We furloughed a lot of healthcare workers. And soon thereafter, we learned that we were going to go into partnership with Franciscan CHI. And during that same period that the UW lost 500 million, we lost 46 million. So, nothing happens in a vacuum. And one of the things is, the New York Times and other groups started calling it, our emergency rooms were eerily quiet. Like there was a period there for like 2 or 3 months where there were no people coming in for strokes or heart attacks. And how could that be in the middle of COVID? Well, I think we realized later that people were so frightened to come in that they were having their heart attacks and their strokes at home and were going undiagnosed, as remarkable as that may seem. The other thing we saw was that as elective procedures got shut down as Anchor had to take a hiatus and wasn't able to see their patients in a recurring theme, a lot of cancer care took a hiatus too. And there was this question of whether we were going to make people more immunosuppressed and make the, cure their cancer, but make them more vulnerable to COVID. A lot of people who we thought, oh, it's just a colonoscopy, we can wait, or it's just a mammogram, there's no harm if we wait 6 months to a year. Well, earlier this year, when things started opening up again, we saw a huge surplus of cancer diagnoses as people started coming back for elective procedures, started coming back to the clinics for assessments of lumps and lab abnormalities. So I think what we would say is that the consequences to cancer care has been very profound in the backdrop of COVID-19. And we run this very uncomfortable interspace right now of trying to care for our patients, not putting them at risk for COVID. I have 2 patients on our 18th floor who have COVID who didn't have it when they came in, captured it in the hospital. It's rare, but it happens. And trying to do this careful balance between treatment and watchful waiting in the context of not putting them at higher risk. Next slide. I think we know that people living with HIV and cancer is a very common problem these days. Non-AIDS defining cancers outstrip those of AIDS defining cancers. Many of those cancers are treatable, can be cured if caught early, and cancer screening is an incredibly important component of that. Next slide. So, what are the cancer screening? Well, the ones that we're doing right now are mammograms, cervical paps, colonoscopy, and colonoscopy recommendations changed in the last year from beginning at age 50 to beginning at age 45, with the recognition that colon cancer risk is starting at a younger age. And we're seeing a lot of people, 30, 40 years old with colon cancer, where we usually didn't start screening to 50. So Jeff mentioned that anal cancer is a disease of older folks. The epidemiology of colon cancer is screening. Lung cancer is huge, and we now have data and insurances that will cover, screening CT scans for lung cancer. The AMC is going to have a study looking at screening people who have 30 plus pack year history of smoking and are over the age of 55 to CT scans and an intervention. And the intervention is a video-based education series on stopping smoking. And the question will be, is the educational component helpful while they're going through their screening as it pertains to stopping smoking? And then, we talk about hepatitis B and C. We don't always think about testing for liver cancer, but we should. And then the importance of the HPV vaccine. And I think I'm going to, if I could have the next slide, I think I'll turn it over to Jeff to talk about that as well. Again, just an emphasis that cancer screening is important. It took a hiatus during COVID. We now appreciate, we're just getting information and data showing what a devastation it was to put that off, to take routine care off. A lot of our visits now are virtual, which are good. They can also be bad in some ways. We don't do physical exams by video. We miss a lot by video visits. When we talk about heightening disparities in care, some people are incredibly sophisticated. They walk their way around Zoom without effort. A large grouping of people don't have computers. They don't know how to access on their cell phones. It magnifies, it doesn't create this even playing field. And then, of course, and I just leave it, the World Health Organization has been focused on the 90-90-90 movement. That's really important. And I think even in the US, I think we're at, Rachel probably knows this better than I do, but I think we're at 70% non-detectable in the US. And so moving toward that 90 goal, but not there. Next slide. So I'm going to just I don't need to remind this group, but the past is the past. But a lot of that stuff came back weirdly in the context of COVID. And I think we've seen kind of shifts in the political mindset. We've seen how social media can amplify certain toxic thoughts and attitudes in a way that we did not anticipate maybe when Facebook was created 15 years ago. Next slide. And, I'm still amazed, when we talk about misinformation, we have a study in our hospital right now. It's an NIH funded study looking at people who've had COVID, and before they're discharged from the hospital, it's placebo controlled. Half will get an anticoagulant called apixaban, and the other half will get nothing. And the idea is to look and see if in the course of a month, giving an anticoagulant can reduce the risk of blood clots. We know that if people are so sick that they're in the intensive care unit, that they benefit from prophylactic blood thinners. We also know that if people are not so sick and their COVID is managed at home, that the anticoagulants don't offer benefit. This middle group is the group we're now wondering about. And I can tell you, I've talked to 15 people over the last 2 weeks. Not one has wanted to take this study up, even though it's incredibly easy, even though it's just a survey. They don't have to come to clinic and there are no blood samples. And the reason, because for the vast majority, and as you might guess, none of these folks were vaccinated. They got their HPV, their COVID in the backdrop of no vaccination, is that they're very paranoid and they're very worried that this information will be shared in nefarious ways. And many of them don't think that the vaccine would have prevented their infection. Next slide. So I'll leave, and then we're going to go to Jeff's portion next. But I do write a blog called COVID Cogitations, and usually like once a month I'll put out information. And there's always a small portion on HIV and COVID. There's always a small portion on HIV and cancer, and then the most of it is just general information. Is hydroxychloroquine useful? Are other drugs helpful? That kind of stuff. So Jeff, I'll hand it over to you now.
Can I ask
Michael,
a question about screening, or should I wait?
Sure.
Yeah, go. Let me go through these 2 slides, and
Okay.
then I'll let you answer your question.
Okay.
And I see Rachel answered Alice's question. There actually has been very little transmission of COVID within the hospital from staff to patients, what are called nosocomial transmission. There has been some, but very, very little of that.
And it's mostly been in lunchrooms between staff who are eating with their masks off.
Staff to staff transmissions are more common, unfortunately, and surprising.
Thank you.
Have gotten COVID in the hospital.
Yeah. So going forward, one of the, as I mentioned at the beginning, we thought we'd have to screen 3 people to find every potential participant in Anchor. We actually screened 2 to find 1, 10,000 to find the almost 5,000 that enrolled in the study. But screening involves doing an anal pap smear. The problem, and in cervical pap smears, the pap smear is quite accurate in identifying people at significant risk of high-grade cervical dysplasia. The cervix is a flat, open structure, and it's easy to sample the entire surface. The anal canal has lots of folds. The high-grade lesions tend to hide in folds. And when we're doing an anal pap smear, or what's called anal cytology, we're not sampling the cells as well as you can the cervix. Therefore, the current algorithms all suggest that unless you have a totally normal anal pap smear, which on the left here is shown as benign, that any slight abnormality to more serious abnormality on the anal pap smears requires the high resolution anoscopy, the full exam. So screening is helpful, but it's not going to screen out the large proportion of people who need to have high resolution anoscopy. Not all those people with an abnormal pap smear will have high-grade dysplasia, but oftentimes minor changes on the pap smear, what we call ascus, which means atypical cells, will have high-grade dysplasia when we do the anoscopy exam. So this is one of the challenges. One other suggestion, which is being done in the cervical screening now, is called co-testing, where you do the pap smear and you do DNA testing for evidence of the high-risk types of HPV, including the type 16 and 18 in particular, but there are about a dozen other types we can test for also. So one suggestion is to use that then to kind of be a little more sensitive. Next slide. So one other suggestion is, when do you do that? Which group of people? So this is one suggestion. This paper was just published last month, and the author actually did a presentation to a webinar to the International Anal Neoplasia Society last month. But there are different approaches here to try to use maybe co-testing to identify subsets of people who would benefit from the exam. So in this scenario, we would go on to anoscopy in anyone with low-grade or high-grade cytology and just use the HPV co-testing in people with ascus. So there's no consensus here, but at some point we're going to have to wrestle with the fact on how do we screen, because not everyone is going to need high-resolution anoscopy, but an awful lot of people with HIV have abnormal cytology. So next slide. And then did you want to ask a question now? Sorry, and then I'll just mention a couple of other studies we have, and then we'll be done.
Sure. With regards to screening, so I do a lot of workshops locally and nationally online for people with HIV. And so in New York State, the recommendation is that everybody with HIV gets an annual pap smear, men, women, whatever. And so I recommend that nationally. I say every person with HIV should be getting an anal pap smear. So the first thing I hear is that significant number of people in the workshops have never heard that before. It's news to them. And secondly, when you dig deeper, the barriers to that are tremendous. My doctor doesn't do it. He wants to refer me to a rectal specialist. I can't get the referral. He's way across town. So there's huge barriers simply to getting an anal pap smear. I think you're all aware of that their barriers are real. And so are we thinking of an annual HRA for everybody with HIV? Because that will be, I think, an insurmountable barrier. Is it still going to be annual pap smears for all people with HIV?
Yeah, so a couple of comments. I think you raised great points. The age for this study was 35 and over. I don't think there's any reason to do pap smears in men under 30, HIV positive, heterosexual men. And under age 30, even when high-grade anal dysplasia is there or high-risk HPV is there, it frequently resolves on its own and clears spontaneously before they're in their mid-30s. So I think when we're talking about screening, we really should be focusing on people 35 and over, like the Anchor study did. You're going to get an awful, if you start doing cytology in men in their early 20s, you're going to find a tremendous number of abnormal pap smears. Most of them are of no long-term consequence to those people. So screening would be something about age 35, like we did in Anchor. It would be annual cytology. Most primary care providers don't know how to do cytology. It actually isn't odd how to do it. And we're actually locally figuring out how to develop some training materials for our local primary care providers in the HIV clinics to begin doing cytology when this paper is published. It is a skill that needs to be taught to primary care providers. In the past, though, and my clinic also had this policy of not doing cytology routinely because we didn't know whether treatment made a difference. So you're going to find that 3/4 of people are going to have an abnormal cytology. And unless you have a trained anoscopist and a clinic capacity to refer those 3/4 of all your cohort, of all your HIV positive participants to high resolution anoscopy, there's no point in doing it. So you're right, a lot of people don't do it. But I think that all will change over the next, couple of years here once the study result is published. And clinics are going to have to teach their primary care providers how to do cytology. And they're going to have to build the capacity, though, to see the large number of people who are going to have abnormal cytologies for high resolution anoscopy. Currently, that is not the standard of care. The New York guidelines are pretty amazing, but they did all that without proof that treatment made a difference. And the Anchor study now completes that guideline recommendation, and that it shows that treatment actually does make a difference, justifying all that front end cost and screening that.
Well, can't a primary care provider take the anal pap smear sample and send it off somewhere? Or
yes, for sure, yeah. But performing a pap smear isn't.
Yeah, because what I say to people is, I say, if you go to your primary care provider and they say, I don't do anal pap smears, I say, you should say to them, why not? You should. You shouldn't be referring me to another specialist. You should be doing this yourself. Is that correct?
Right.
Is that what I should be
Well,
encouraging
the
people to say?
main why not reason now has been we don't have anyone who can follow up on your abnormal pap smear, and that's the problem right now.
Okay, but
so and also teaching primary care providers how to do it also is another piece of that.
Okay, because I got referred right away when mine came back abnormal. I just got referred out of clinic, so that's an option too, right?
If you have someone in your community who's doing high resolution anoscopy and has capacity, which we don't have anywhere, capacity to start screening everyone now, that capacity maybe in San Francisco or one or two other centers that really put a lot of resources into this. There's, a fair number of providers in New York. There's a large clinic in Chicago, San Francisco. That's about it in terms of capacity to embark on screening of everyone who's HIV positive currently.
So you're saying there are large areas of the country where if somebody has an abnormal pap smear, there is nothing they can do.
Right. Yeah, I see people from Alaska to Montana in my practice here in Seattle.
That's crazy.
There's no one in the state of Alaska. There's no one in the state of Alaska doing high resolution endoscopy. There's no one in the state of Montana doing high resolution endoscopy. I don't know of anyone in Idaho. People from Spokane, 280 miles away, come to see me in Seattle.
And I can say, I think this is definitely changed in Boston, but even as recently as within this decade in Boston, we weren't doing, I'm now obviously in Seattle with you all, but I trained in Boston. We weren't doing them in Boston because of this question of did we need to intervene on HSIL? And so they had high resolution anoscopy there, but they thought unless we prove that high resolution anoscopy with an intervention is important, then we won't send people to that. So we won't do the PAP. And that's in Boston. That's changed in the past 7 years. And I don't know when they changed that, but they've been waiting on the results of this trial.
Funny because New York State has had that recommendation for years now, the annual pap smears, for a long time.
Right, but they had no real data to show that treatment made a difference.
Right, I'm surprised they've had it for so long.
Yeah, I am too, actually. In some ways, they're very progressive, but in some ways, they were ahead of the curve at the same time, I think.
Yeah, and so I'm getting a sense here just of that community people are feeling a little bit alarmed about the lack of being able to move forward with this. And so it seems to me like that would be a natural place for community advocacy to start forming. Do we have any ideas of how community advocates might be able to take what we've just talked about now and to help get to see that Alaska one day has HRA abilities themselves?
Well, I know, at our Ryan White Clinic, we have a community. Oh, go ahead, David.
Sorry, I would be really curious to hear what the CAB members, there are a number of national and local CAB members for Anchor on this call, and I'm sure they've already given it a fair amount of thought. Bill, Aldister, I don't know if Jeff is still on. I know that Peter was on.
And Larry,
was on. Do you guys have any thoughts about that?
Well, actually, we haven't been involved in advocacy so much. So one of the issues would be transforming the CAB to do more advocacy. And I think that's a possibility. I think that's something that our CAB should discuss, actually, in changing the CAB's focus to be more of a national advocacy of the results of this study.
Alice, you had your hand up.
Yes, I did. I raised my hand because I'm recently back from 6 months in Scotland, helping my brother with some health issues. And I have gained a massive appreciation for the advantages and privilege I have being in a 10 million population catchment area and accessibility to specializations as contrasted with about a 35,000 people catchment area around Oban on the west coast of Scotland, where almost all the treatment of more than the basic stuff requires going down to either Glasgow or Edinburgh. Because this is all the way down to the level of physiotherapists, not high resolution endoscopy, because they don't have the population in the rural areas to support the specialists. So we have to be very careful not to demand too much that cannot be created in a reasonable manner, but we are likely to have much more success if we can advocate in the areas that have the large catchment population initially, to get the people trained in those areas, to at least that way let people in rural areas, as Jeff is seeing, travel into the areas where the specialists are there and trained, and at least start with that. If we start demanding the whole and perfect system, then the good systems aren't going to be developed. So we have to be careful about that. Yes, though, I do think it's important for us to advocate. Thank you.
Jeff and, oh, I'm sorry, I didn't mean to speak over you. Jeff and David, do you think that, now as we are endoscopists or GI doctors are doing fewer colonoscopies for routine screening, as we're doing more fecal occult blood testing, this is something that we could advocate? I mean, these are people who are used to looking at bums, used to doing procedures, used to looking in mucosa. They generally don't stop there on their way in with a fancier scope. But I'm not aware of that many GI endoscopists around the country taking up HRA. And is that somewhere where potentially advocacy could be working kind of on those societies to increase the interest among those professionals?
Jeff, do you want to take that first? I think the answer is yes.
Yeah.
Yes, but what do you think?
Possibly, I have to say, but it's interesting. Virginia Mason, I do all my endoscopy in the GI suite. There hasn't been much interest in what I'm doing there with all the other GI docs all around me there. And I think I only know one in Washington, D.C. One of our endoscopists for Anchor is a gastroenterologist, Jessica Corman. I'm not aware of any others. We have a mixture of surgeons, primary care providers, and so forth. I think to get back to community advocacy, I really think it's going to need to be at the primary care level. I know, like at Madison Clinic at Harborview, we have a community advisory board. I think it's really going to be at that primary care level that the advocacy to start doing what Mark was saying New York did years ago, is begin implementing routine screening guidelines, and then building the capacity to where you send all those people who have abnormal cytologies. And, that advocacy, I really think, has to happen at the primary care level. And different institutions, there's a lot of procedures like this where there are turf battles all over the country for privileges over which specialists can be doing which procedures. Unfortunately, this is one where there hasn't been a fight over it yet, but I think eventually there may be. There's no certification board. That's the other question. Who's going to certify you to be? We had to write our own criteria at Harborview and Virginia Mason and Polyclinic on how do you say someone's competent. There's no society that's certifying people as competent to do endoscopy, high resolution endoscopy, and that's going to need something needs to be developed over time, and that's probably got to be a joint effort across the different specialists, not just owned by surgeons or gastroenterologists or gynecologists. So I think that's going to be the next battle over who's going to take ownership over providing some form of credentialing like there is for cervical colposcopy.
Hey Jeff, can I ask a question? Is Anchor, in terms of like the guidelines for screening for cancer, I mean, is there a central repository for screening of cancer, or is it really just primary care providers? And is Anchor doing anything to influence that?
Well, I think Anchor has been, the group at UCSF has really trained many of us all around the country. So they've got a lot of experience in training people. But I think their training requirements, quite honestly, are too onerous. What we did for Anchor, and Joel Pileski, the principal
believe me,
investigator,
I am well aware.
His philosophy, and I totally agree, was there was one chance to show the treatment makes a difference. So you had to be sure you had people doing it really well, because this was the only study that was ever going to be done like this. But this is the way you're going to build capacity across the nation, the way we did it for this study.
No, it took you. I mean, I know how long it took you.
Yeah.
And you asked a kind of a general question about, is there any kind of cancer guidelines group?
Right. Is there?
There is, but not so. Cancer screening guidelines kind of go by a number of different groups, so GI, gynecology, internal medicine. For the National Cancer Center, NCCN guidelines offer guidelines too, but they're more focused on treatment and not so much on screening because other groups have already taken that mantle up. So I think this will be interesting. The NCCN did develop guidelines specific for HIV, I think it was 2 years ago, and they developed guidelines for KS and lymphoma, and they've kind of settled more or less on other types of cancers. If you're HIV positive, you should be getting the same treatment whether you're HIV plus or negative. But there aren't any kind of screening guidelines. It'll be really interesting to see when this study gets published. What are the editorials going to be focused on? What are the professional guidelines going to be taking over? The HPV anal neoplasia group that Jeff mentioned, that society has a potential huge role in what's coming, but individual societies like the GI societies are going to be really important also.
Has anyone sort of owned the lung cancer screening? Is that a model to follow or not?
So lung cancer screening is done different in different places. It's mostly done in cancer centers and not primary care doctors, but the guidelines are pretty straightforward. It's just that you need to have a CT, you need to have a program that's certified to do it well. You need to have radiologists who know how to read those really well. You need to have a clinical navigator or a patient navigator to lead those patients in the right direction. So most cancer centers, including yours, will have robust lung cancer screening, but it falls on the people who are taking care of HIV to put those referrals in.
It brings up one other point. One thing we should mention is one really important piece of the care continuum here is the pathologist. This pathology here, unfortunately, pathology is not as black and white as we like to think it is. There are many shades of gray here, particularly in determining what's high grade and what's low grade, and even what's an invasive cancer. Those cases that David said we present twice a year, several of them are questionable cancer cases where there may not be consensus even among the pathologists locally and nationally who are reading it. So when I set up our clinic at Harborview, the first thing I went in 2012 was when I met with the pathologists and determined what criteria they were using, what classification they're going to be using. One of those slides that David showed earlier calls it carcinoma in situ for high-grade anal dysplasia. That's an archaic term that should not be used. I still see people, and just saw a person the other day who was referred to Seattle Cancer Care Alliance because she was told she had anal cancer. She had high-grade anal dysplasia. Her pathology reports that squamous carcinoma in situ. She was convinced she had anal cancer, and she didn't. And pathologists should not use that term. So there's going to be another piece of training here, is educating pathologists on the terminology that we're using here, so everything's diagnosed and treated in a standard form also.
Jeff, I wonder if you want to speak. Rachel brought up, I saw in the chat, HPV vaccines, and I think you have a slide.
The AMC, there are studies looking at different topical treatments, so I won't spend, next slide.
Sure.
And we're looking at the HPV vaccine, the VIVA study, a local study, to see if the HPV vaccine, which is incredibly efficacious at preventing HPV infection, about whether it has a therapeutic benefit at preventing recurrent high-grade dysplasia. As I mentioned in the anchor study, quite a few people in the treatment group needed multiple treatments, usually not because the primary lesion came back, but because they developed secondary areas that needed treatment. So we're doing a study looking at Gardasil 9 vaccine to see if it prevents recurrent anal or vulvar, which also recurs frequently. And the next slide. Well, we just skip. This is what actually an anoscopic exam looks like. This is actually the skin transition to mucous membranes. This is what it looks like when we put iodine on it. And then next couple of these are what actually high-grade dysplasia looks like. If you go back one there, we see multiple vascular abnormalities and so forth. This is actually what we're looking at through the scope. Next slide. And that's magnified 25 times, which is a high magnification. Go on. So HPV vaccination recommendations are currently now, as of August of 2019, included permissive vaccination above age 26. It used to be that vaccination was only recommended for prevention up to age 26. Now it's up to age 45. The logic really here being that there are 9 different HPV strains in the vaccine. The 2 that common ones cause warts, type 6 and 11, and then 16, 18, and 5 other cancer-causing high-risk types. So the feeling is that someone probably hasn't been infected with all those types in adulthood, and there's still some preventative benefit to the vaccine. So it's now permissive to vaccinate people up to age 45. So
permitted, but not often reimbursed or covered.
No,
by
it's been reimbursed most everywhere. That I haven't seen anyone not get reimbursed since 2019 with the new CDC guidelines who's under age 45. Yeah, most insurers are paying because it's part of the ACIP, the immunization practice guideline recommendations. And then I'll come back to one thing that Anne asked. I think the other group that may take, hopefully, influence outcomes here and guidelines is the Public Health Service HIV/AIDS treatment and opportunistic infection guidelines panel. I think it's going to be interesting to see how quickly they include this recommendation in their guidelines. I think that's the group that may modify guidelines the soonest, but we'll have to wait and see.
Next slide. Oops.
Yeah, that's the last slide. I know we're running way over here, but
yeah,
that was the last slides we had. So
okay, great. So I wanted to give people just we are over time, but I see that there was some stuff. I'm just checking in the chat to see if there was anything there. Alistair was asking about the home samples for colonoscopy risk versus. Alistair, did you want to bring up that question, or are you?
My question was basically, do we have the data that tells us how comparatively effective the home kits that are sent out, that people send samples back, how accurate those tend to be as contrasted with formal colonoscopy?
Yeah, Alistair.
Because they haven't been around for that long, as far as I know, but a lot of people are relying on them.
Yeah, so Alistair, they haven't been around for a long time, but they are pretty, they're looking at DNA from cancer cells, and that's what those tests do. Those are not looking for occult blood. And those are now reimbursed by insurance companies. They do make a difference. The issue is that if it comes back positive, you still need a colonoscopy. But if it comes back negative, a lot of people who don't want to go through colonoscopy or whose health is too fragile, it's a really great option, So I think we'll find that's going to be used increasingly more common, it'll be more common. The other thing that we didn't talk about are DNA tests from the blood. And, tumor tissue sheds DNA, and some of the newer circulating DNA lab studies are really quite remarkable. And we could envision a time in the very near future, like in the next couple of years, where they'll be used not just for early diagnosis of recurrence, but for cancer screening as well. And that will take a lot out of the need for invasive procedures.
That's very reassuring. Thank you.
Yeah.
Well, I think we should maybe wrap things up, because we've talked about a lot. And, I was initially excited about the anchor study results, and I still am excited about those. I remember when you guys set up this study to begin with, and you were talking about you were going to be randomizing people to get no treatment or treatment. And it just seemed like it was, how is this going to work? And it's a wonderful testament to, I think, people like you, Jeffrey and David, and to the CAB members that you had, that this study was enrolling so well and was stopped early for such good reasons. The issues that we're talking about, obviously, I think are going to have to be wrestled with a lot more by more than just us here on this call, but I think it's hopeful to have problems like this to work on, as opposed to having a study result that didn't give us any sort of definitive answer where we don't know the next steps forward. So I really thank every one of you for joining us tonight, and I hope that you had some of your own curiosities answered about these results from the anchor study. We have a paper to await it seems. That's going to be the next big moment for us. So we'll be on the lookout for that. And I'm sure you guys will highlight it for us when it does finally come out. If it's not with trumpets, it'll at least be through an email.
Will the slides be available?
Can we make the slides available?
Sure.
Sure. Okay. I can make
Great.
them available to you all. Yes. So definitely, if
Thank
you
you so
registered
much.
for tonight, I'll send them out to you so you guys get it. Anyone who is registered for tonight. All right.
I'll use a couple
Yes.
of them in my trainings.
Who had a question?
Right.
Michael, it's Alistair again.
Yes.
Is this the recording of this session likely to be available?
It is. I make it available. It'll be available on our Facebook page as well as on YouTube. And I will email out the link when I have that done. So I'll get work on that right after this meeting is over. And that'll usually go up sometime tonight. And so by tomorrow, you'll have the link and you can send other people to check out what we talked about tonight.
Thank you very much, because I think this is going to be very helpful in spreading the word about it throughout the community.
Yes, I think so too. That's why I wanted to have this meeting. I was looking forward to it. Which again, I wanted to thank you, Jeff and David. Beautiful job as always. And I really appreciate you bringing your expertise to us to help us understand the implications that are behind these wonderful results that the study has achieved.
I want to thank everyone for their great questions and for staying with us, because as you can see, there's a lot of complexities here and a lot to work on. So I think everyone's advocacy is going to be really important in the coming months and years as we embark on implementing these incredible findings.
Thank you.
Thank you.
All right. Well, and I want to wish you all a happy holiday coming up here. If you are celebrating Thanksgiving, I hope you eat well and remember to be thankful for something. Doesn't matter what it is, just be thankful for something. That's where it all starts.
Don't take Zantac. You can use Pepsid, okay?
Okay, thank you. I won't.
Thank you.
Thanks all. Have a good evening. Thank you. It was great to see you again.
Thank you.
Be well.
Bye, everyone.
Bye-bye.
Thank you, everyone. Bye for now.
Bye-bye.
Thank you.
All right. Take care.